On Rare is a podcast developed by BridgeBio to educate ourselves and the public about living with a rare disease. Since our guests aren't scripted and are free to speak their minds, their views and opinions don't necessarily reflect the views and policy of BridgeBio Pharma. Now, we hope you enjoy the podcast.
Hello and welcome to this very special bonus edition of On Rare featuring Dr. Jonathan Fox, Medical Director of the Cardiorenal Program at BridgeBio. David had a really great conversation with Dr. Fox about transthyretin amyloidosis, or ATTR, as part of the two-part podcast with Eric, a man living with ATTR. Given the complexities and nuances of this condition, we wanted to take the time to go a little deeper to gain more knowledge and understanding of ATTR, and Dr. Fox is just the guy to help us.
Jonathan is a cardiologist with many years of clinical experience. He's also a friend and a wonderful person, and I'm so pleased to welcome you, Jonathan.
Thank you, David.
So first, can you say what ATTR-CM stands for and what kind of condition it is? And people kind of call it by different names, so maybe you could also say the types of ATTR that are out there.
Sure, I'd be happy to do that. The abbreviation ATTR stands for transthyretin amyloidosis. So transthyretin is often abbreviated as TTR, and the A stands for amyloidosis. The CM stands for cardiomyopathy, which basically means an intrinsic disease of the heart muscle. And there are different kinds of cardiomyopathy, but this is a special one in terms of the population in which it occurs and both the mechanism of the disease and the characteristics of the patients who live with this disease.
Thank you, Jonathan. It's my understanding that people develop ATTR-CM without a family history, and then some people do have a family history. There's a genetic cause of ATTR-CM. Am I correct? And can you explain that a bit more?
Yeah, that's right, David. Transthyretin amyloidosis is a systemic disease. It is caused by the dissociation of this protein, transthyretin, which is made by the liver and put out into the bloodstream where it circulates. And it's put out by the liver in what I like to call four-part harmony. It's made up of four identical subunits, or what we call a tetramer. And what happens in people who develop amyloidosis from transthyretin is that the four-part harmony sort of loses the backbeat, if you will, and falls apart into those four identical subunits. And those subunits, for reasons that are quite technical that I won't go into, are prone to what we call misfold. That is, they normally exist in the correct three-dimensional shape, but when they have fallen apart from the tetramer, they take on an abnormal shape, and that promotes their aggregation into clumps of misfolded transthyretin. And those clumps of misfolded transthyretin are deposited in a whole range of organs and tissues, including the heart. They don't actually get inside the heart muscle cells, but they accumulate in the space between the heart muscle cells, and they disrupt the normal pumping function of the heart, the way that the heart muscle cells normally work. They pull together as a team, and these clumps of abnormal protein interfere with that function. As I said a moment ago, it's a systemic disease. So these clumps of transthyretin accumulate in other tissues, and there's another important clinical picture of the disease where the clumps predominantly affect the nerves. And we differentiate in medicine between the central nervous system, which is the brain and spinal cord, and the peripheral nervous system, which is the nerves that are out into the arms and legs and so forth. And in people with what's known as ATTR polyneuropathy, it affects motor function, or the ability of people to use their muscles. It affects their ability to feel pain or other sensations. And in fact, they often have a painful condition where the sensory nerves are sending signals of pain to the brain that are independent of any stimuli, if you will. Both of these forms of the disease are out there and are progressive and lead to serious disability and even death in some people. And maybe I'll just pause there and see if you want me to clarify anything that I just said.
That was excellent, Jonathan. And the one thing I thought, if people didn't understand you later, explained it. So let's just proceed. This is fabulous. Now I'm thinking of a new podcast only featuring you explaining complex medical issues to people.
It's a backbeat. You can't lose it.
Yes. Jonathan, as we were talking before, some people who have transthyretin amyloidosis, the cause is genetic, and then there are other people where the cause is not genetic. And do we know what causes ATTR with cardiomyopathy that does not come from inheritance?
So the disease can develop in people without any mutations in the gene that encodes transthyretin called genetic variants. But it also, there are these changes in the primary sequence of the protein made by the liver that promote development and progression of the disease. In the so-called wild type form that occurs in people without changes in their genetic makeup, it's related to aging in ways that are not well understood. But there's something about how the body regulates the production of various proteins that the older you are, the more prone you are for mistakes to be made, if you will, in either the production or the turnover of some of those proteins. So the likelihood that this tetramer will fall apart and lead to clumping of the protein increases with age, whether or not there is a variant present. And in people who are born with a change in the genetic code for the protein, those, what we call pathological variants, those that promote acceleration of the disease, they tend to develop the disease earlier in life. It tends to progress more rapidly. And of course, if it's in the germline, meaning if they were born with it, it's in their egg cells and sperm cells, if you will. Mm-hmm. And there's a 50-50 chance that they'll pass it on to their offspring in what we call an autosomal dominant. That is, all you need is one bad copy, and that increases your risk of the disease.
Right.
The wild type form was thought to be extremely rare, not even a few years ago. Mm-hmm. But it's like with a lot of things that once you start looking, you find them. And the development of effective treatments for this disease have in fact accelerated the extent to which it's diagnosed in people for a couple of different reasons. There's increased awareness amongst physicians that they should be looking for this. For example, in ATTR cardiomyopathy, the presentation is one of heart failure. Heart failure is a common disease, but it has different causes. But it's being increasingly recognized by cardiologists in particular that if they have someone come to their clinic with new onset heart failure with particular clinical characteristics, it's one of the things that they should think of. And the reason why it's so important is, again, now we have some effective therapies, and the information coming from the clinical trials with these drug products is that the earlier in the progression of the disease that you intervene with an effective drug, the better these patients do.
Yeah. And I think we find in rare diseases in general that physicians are not motivated to make an exact diagnosis if it won't matter with regards to treatment. But now for a person who presents with heart failure or cardiomyopathy, a more exact diagnosis could potentially lead to a treatment that targets that specific problem. So one question remains: if everything is working correctly, everyone has TTR circulating in their bloodstream, what does it do? What is it for?
So transthyretin has been around for a long time with respect to evolution. All organisms with a backbone called vertebrates have transthyretin. And the function of transthyretin, as the name actually implies, it is a transporter of thyroid hormone and retinoic acid or vitamin A. So the trans is the transporter, the thigh is the thyroid, and the retin is retinoic acid or retinol.
And another question, this is based on something you said, is that when the tetramer comes apart and misfolds, it forms amyloid deposits that could go into any organ system. Do I have that right?
That's right.
So I just have to ask, I think most people have heard of amyloid because of its connection to Alzheimer's. And I don't think this condition is connected to Alzheimer's. And I wonder if transthyretin amyloidosis does cause deposits in the central nervous system, or is that not one of the organs that it
transthyretin
affects?
is made in the central nervous system. It circulates in the cerebrospinal fluid in the brain and the spinal cord. And in fact, it can clump and form amyloid plaques in the central nervous system, which can be seen on an MRI. But that is a particularly rare form of transthyretin amyloidosis that seems to only occur in people with particular mutations in the gene. Now, going back to the first part of your question, there are many different amyloidoses, and Alzheimer's is a form of amyloidosis that does not involve transthyretin. It involves some other proteins that clump and form so-called plaques in the brain. There's one particular form which affects the heart and can often be confused with transthyretin amyloid cardiomyopathy, which is light chain amyloid. It's a blood cancer that comes from the cells that make antibodies in the bone marrow. And the treatment is to treat the cancer.
Right.
Since people with AL cardiomyopathy and people with TTR cardiomyopathy can often look very similar from a clinical point of view, in order to make the diagnosis, you really have to exclude the possibility of AL. Again, it has a very different treatment and, in fact, is often rapidly progressive and needs to be addressed urgently.
And the patient advocacy organizations around transthyretin amyloidosis also cover light chain amyloidosis. They cover the cardiac amyloidoses together.
That's right. David, I wonder if I could just go back for a moment to talk a little bit more about the variant form of the disease. I think it's important, especially for our audience. The predominant variant in the US is called the V122I variant, and it's present in about 3.5% of Black Americans. And similarly, in other populations, like in the UK and France and some other places, where people of West African descent also live. It's really, really important that we, the medical community, come up with better ways of reaching that particular patient population, because those people who carry a variant often present at an earlier age. Their disease progresses more rapidly. So it's that much more important that we reach those people and get them treated as early as possible.
Yeah. Thank you for making that point. And I think that we know that the experience of the African Americans in the U.S. healthcare system has not been
not great,
positive, and sometimes very terrible. So there's a reduced level of trust, and there's also less access for many people with African American backgrounds. But if a diagnosis is made early, this could make a huge difference in people's lives. So very important to get the word out about this. And thank you for mentioning it. I wonder if I could ask you, first of all, the relationship of carpal tunnel syndrome with ATTR-CM.
Sure. TTR amyloidosis, or transthyretin amyloidosis, is a systemic disease. The misfolded clumps of transthyretin find their way into a variety of tissues. And maybe we kind of glossed it over earlier, but there are, in fact, people who have both manifestations of the heart failure form of the disease and the nerve failure form of the disease, a so-called overlap presentation. And one of those red flags is a series of orthopedic problems. And it includes carpal tunnel syndrome, as well as joint replacements that seem to come kind of out of nowhere. It includes another condition known as spinal stenosis. It can also present as a spontaneous rupture of the biceps tendon, so that the biceps muscle sort of balls up because it's disconnected from one of its attachments. And all of these, what they have in common is the TTR amyloid in those locations, gumming up the works. So carpal tunnel is a sheath of connective tissue that is on the inside of the wrist. And under that sheath runs all of the nerves and blood vessels and tendons and things that connect the fingers of the hand and the other muscles of the hand to the muscles of the forearm. And there are people who develop carpal tunnel often as an occupational hazard, if you will, repeated motion injury. And the treatment is a rather simple operation known as a carpal tunnel release. The orthopedic surgeon goes in and then they make some cuts and they release the pressure, because it's a buildup of abnormal connective tissue that causes carpal tunnel. And it compresses the nerves and the muscles in that sheath. It's painful and can interfere with their function. But in amyloidosis, some people show up with carpal tunnel in both wrists without much of an occupational history that would suggest why they have it in both wrists, or even in the one. And what the amyloidologists, as I like to call them, have been increasingly doing is getting the orthopedic surgeons to take that tissue that they remove at surgery and send it to the laboratory to be analyzed for the presence of TTR amyloid. It turns out that those people who have had carpal tunnel release surgery often develop the heart failure manifestations within the following 10 years. When the clumps of TTR amyloid accumulate in the heart, it often impairs the ability of the heart to push that blood out to the rest of the body. And so, what we call cardiac output, or the amount of blood that is pushed out with each heartbeat, drops. And that's not a good thing. When people with atrial fibrillation, sometimes they can be treated with drugs to try and get them back into a normal rhythm. The usual thing is to shock the heart like you would do to resuscitate someone with a cardiac arrest. The same idea, although it's done in a hospital under controlled conditions and with sedation, if not anesthesia, to shock the heart back into that normal rhythm. And often that can work, but usually doesn't last. People go back into atrial fibrillation. And the reason why all of this is important is when that left atrium is jiggling along in fibrillation, it tends to accumulate blood clots. And if one of those shakes loose, it then gets pushed out into the body and especially into the brain where it can cause a stroke. So
Wow.
that's
Wow.
the problem at hand, is to really it's stroke prevention.
Wow.
It used to be until about 8 or 10 years ago that to make the specific diagnosis of ATTR amyloid required a heart muscle biopsy. And that may sound a bit scary to people, but people who've had a heart transplant and are at risk for rejection of their graft, those people undergo routine biopsy very often to monitor for rejection. There was a seminal paper that was published in 2016 that described a non-invasive way of diagnosing ATTR amyloid. And it relies on basically what's called a bone scan. And it's been around for a long time. So infections will light up on a bone scan. Cancer will light up on a bone scan. And it turns out that cardiac amyloid from TTR lights up on a bone scan. It was one of those things that was probably stumbled upon by accident. But somebody who was observant, or a group of physician scientists who were particularly observant, said, hey, this could be useful. It probably took about 10 or more years to establish it as a routine diagnostic maneuver, but it's really revolutionized. So the combination of increased disease awareness, the availability of drugs under development or on the marketplace, and a non-invasive way of diagnosing the disease has completely blown the field wide open.
Wow. Wow. Amazing. Jonathan, I hope this is not typical for people with ATTR with cardiomyopathy, but another man that I knew named Len had ATTR and received a heart transplant. And I wonder how common that is, and if there's hope that with early diagnosis and treatment that heart transplants can be avoided for people with ATTR CM.
Well, a heart transplant is, in some people, a treatment option, but it is unusual. Part of it is the supply of donor organs is limited, but perhaps more importantly, in order to be a good candidate for a heart transplant, the rest of you needs to be in pretty good shape. It's quite a big deal to go through the operation and the subsequent treatment to suppress the immune system to avoid rejection of the new heart. And this is a disease of older people by and large. Just because they have TTR amyloidosis doesn't make them immune to the other things that can affect older people: diabetes, hypertension, kidney disease, liver disease, all those things, cancer. And a lot of these people have more than one disease. They have their ATTR cardiomyopathy and some of this other stuff, and it's the other stuff that makes them either a good or a bad candidate for a new heart. In Len's case, he was otherwise in good shape. Interestingly enough, people with wild type ATTR cardiomyopathy, for reasons we don't understand, there seems to be a common thread of people who used to be quite athletic. So they are often lean and well-muscled, and or they're runners or avid hikers or what have you. And in fact, one of the chief complaints we've heard is they really miss the ability to do that sort of physical activity. So, in Len's case, he was very lucky that he was otherwise in good health despite having a bad heart. And there are criteria for listing for a transplant that need to be adhered to as well, but it is unusual.
So it's unusual as a treatment option, and it really is limited to people who are otherwise healthy. And as we age, as you point out, we accumulate a variety of ailments, not just ATTR.
Yeah, I mean, it's true for anyone with what we would call end-stage heart failure.
Yeah.
The rest of them
Yeah.
needs to be in good shape if they're to be listed for a transplant.
Thank you. That's very helpful. You are fascinating to listen to. You provided us with a great background on not just about ATTR, but about cardiac functioning. And you made a difficult to understand and complex medical explanation into a compelling story. And we're really grateful to you and really happy to share this with the listeners of On Rare. So thank you so much.
Well, as you could probably tell, I love to teach.
Yeah.
I love doing this. It's fun.
Good.
Thank you, David.
This additional information was incredibly helpful. Thank you, Dr. Fox. Thank you, David, for a great conversation. A special thanks to our producer, Amy Brooks. Write to us with any comments, ideas, suggestions, feedback at onrare@bridgebio.com. And check out Eric's story about living with ATTR in our 2-part series wherever you get your podcasts. We look forward to you joining us for our next conversation on Rare.